Now we'll move on to the another important session, the pediatric genital dermatosis and vaccines against STI. To start the proceedings, I invite the session coordinator, Dr. V. Sirisha. Over to Dr. Sirisha.
Thank you, sir. A very good afternoon, one and all. We'll be now beginning with the next session, which is on pediatric genital dermatosis and vaccines against STI. It's my privilege to invite the chairpersons for this session, Dr. Dinesh Mathur sir, Dr. Shamanta Barua sir, and Dr. Madhubabu sir.
Good afternoon.
Requesting the technical team to please display the CVs. Welcome, sir, Dr. Dinesh Mathur, sir. Sir is MBBS, MD in General Medicine and Dermatology and STD, MBA, and Fellow HIV/AIDS, Fellow ICMCH and Indian Academy of Dermatology. Currently, sir is a professor and head of the Department of Skin and STD, JNU Medical College, Jaipur. With more than 90 publications and 500 presentations, sir has various awards, honors, and achievements to his credits. His main areas of interest are STD, HIV/AIDS, clinical dermatology, and cosmetology. We welcome you, sir.
Thank you very much.
Our next moderator is Dr. Shamanta Barua, sir, Dr. Madhubabu, sir, who is a professor. Okay. Let me invite Dr. Shamanta Barua, sir, who is the head Department of Dermatology, Assam Medical College and Hospital, Dibrugarh, Assam. Sir has various honors and awards. He has been awarded the Economic Times Inspiring Dermatologist of India in 2020 and Dr. Ellen Sinha Memorial Award at Dermacon 2015. Is a reviewer of 8 national international index journals and has more than 100 presentations and publications. Sir is the president of Association of Cutaneous Surgeons and member Specialist Advisory Board, National Board of Examination. Welcome, sir.
And recently has conducted a wonderful hybrid conference of ASTICON. Thank you very much, sir.
Thank you. Wonderful to be here. Thanks.
Our next chairperson is Dr. Madhubabu, sir, who is a professor and HOD of DVL, Department of DVL, Kakatiya Medical College, Warangal. Sir is a senior consultant dermatologist, STD specialist, cosmetologist, HIV/AIDS, and sexual medicine consultant. He has held various posts like organizing secretary in the 33rd AP State Cuticon 2013 and as joint secretary for AP State Cuticon 2005 and 2009. Sir has conducted several workshops and guest lectures for healthcare providers on HIV/AIDS and sexual problems. And he has 10 original index publications in national journals and has acted as a state coordinator for AP-SACS for sentinel surveillance for a period of 5 years. Welcome, sir.
Thank you very much, Agnes, Gamti, and Sirisha.
I now request the chairpersons to introduce our speakers.
Nothing is coming on the screen.
Yeah. First speaker, CV, Srinivas.
Yes, this is, we welcome Dr. DSS Srinivas Prasad, who is a MD in DVD, and he has got present affiliation and designated professor in Department of DVL, Guntur Medical College, Andhra Pradesh. And he has got more than 7 publications and presentations many. And awards and honors, he has won scholarships in international conference in IASTD and AIDS held in New Delhi. He won scholarship twice in National Conference of HIV and second prize twice in National Conference of HIV. Papers and posters and state national conferences in various conferences. As speaker in CME and CME on Dr. Natraz and zonal CME of Andhra Pradesh and zonal CME of IADVL. Besides that, he has presented many research papers and authors and co-authors in many chapters, and he is instructor of BCLS course in Guntur Medical College, and he was SAC State AIDS Clinical Expert Panel member in Andhra Pradesh. Because I remember there were lot many meetings at Tirupati at that time. I do not know whether he was there or not. And he was a resource person of AP-SACS. So we welcome Dr. DSS Srinivas Prasad. No audio is coming to me. Is it?
Thank you, sir. Shall I proceed?
Yes, please.
Good afternoon, everybody. I would like to start my talk by paying homage to my divine parents and thanking my teachers.
Make it full screen, Srinivas.
Yeah, I'm doing
Make it full screen, please.
full screen.
Down, right on your computer, and then you will find an icon. Or even you can get it done by top left. Down right, there are 3 icons. Right of your.
Sir, right next to the volume.
Yeah.
These are the references. The ones that are yellow, in yellow are the genital discharges. These are the pediatric STIs. Now, what are the modes of transmission of sexually transmitted diseases in pediatric age group? Well, as all of you know, it is not only the sexual mode of transmission through which the STDs are transmitted to the pediatric age group. Maybe transplantal transmission, it can be intrapartum transmission, it can be postnatal transmission, or as in adults, it can be contact transmission through blood, and it can be sexual transmission. Respected seniors, dear colleagues, and my dear PGs, the topics that I am going to cover today are child sexual abuse, need for counseling, and the approach for the counseling. As most of the delegates here are the PGs, my target audience will be PGs, and my topic will be simple because of 2 reasons. 1, that my target audience are the PGs, and 2, because of the time constraints. I have slightly modified this definition by Barnard regarding counseling. The means by which one person helps the second person to clarify his or her situation so that the second person can decide the future line of action. That is what is counseling. Now, whom to be counseled? Is it the parents? Is it the children? Or is it both the parents and the children? No. What is the need to counsel? Or in other words, why should the parents and the children be counseled? The parents should know that it is not only through sexual contact that the sexually transmitted diseases will be transmitted. And second thing, the parents should understand that there will be a lot of trauma because of the physical and psychological impact because of these STDs. And there will be immediate and long-term consequences because of the sexually transmitted diseases to the child. There are various modes of support like medical, psychological, social, and legal supports for the child and the family. And the counseling will help them to know about these supports. And finally, it is mandatory on part of the counselors to tell about the POXO Act. So these are the needs for counseling. Now, whom to be counseled? As I already mentioned, is both the parents and the children should be counseled. Now, we are discussing about child sexual abuse. Though there are different modes of transmission like transplacental transmission, intrapartum transmission, and postnatal transmission, we are discussing in this slide and the earlier slides regarding child sexual abuse because the transplacental, intrapartum, and post-placental transmissions are on a decline, on a steep decline because of the rapid advances in the management. Whereas the sexually transmitted diseases in pediatrics because of child sexual abuse are on an alarming rise. There may be some cases of sexually transmitted diseases in adolescents because of sexual activity, but child sexual abuse is bearing the main bulk. Now, what is child sexual abuse? It is the involvement of a child or an adolescent in sexual activity which he or she cannot fully understand or for which the child or adolescent is not developmentally prepared, or that act which violates the laws of the society. So this is the definition of child sexual abuse. Children can be sexually abused by both the adults and other children who, by virtue of their age and state of development, are in a position of responsibility or trust or power over the victim. CSA involves the intent to gratify or satisfy the needs of the perpetuator. Sometimes it is not the perpetuator, it can be another third party also who is seeking power over the child and who may be forcing the perpetuator to commit CSA. The true prevalence of CSA is difficult to estimate due to various factors like inadequate data, which in turn is due to underreporting by the victims and their families and social agencies because of various reasons. Now, CSA is totally different from sexual play and has to be distinguished from the sexual play by the healthcare professional. What is sexual play? It is the sexual activity by adults and children. It can be of same or opposite sex and separated by not more than 4 years, that is almost of the same age. And in sexual play, there will not be any force or coercion. This slide is self-explanatory. The types of CSA, first one is contact CSA. It can be penetrative or non-penetrative, or it can be non-contact CSA in the form of exposure of the child to the pornography or taking sexually explicit images of the child. It can be exploring of sexuality between the minors. These are the types of CSA. Now, when to suspect CSA? These are the increasing indexes of suspicion. Disclosure by the child, recurrent urinary tract infections, and pregnancy should give us a strong, in fact, the strongest index of suspicion. Likewise, sexualized behavior in a child and symptoms of post-traumatic stress disorder like nightmares and flashbacks should give us a moderate index of suspicion of CSA. Now, definitely there will be severe consequences of CSA. Why? Because the trauma is experienced in a stage when the understanding of the self, others, and the world are being formed in the child. In this stage, this trauma is being experienced. So definitely there will be immediate as well as long-term consequences like psychological trauma and as well as STDs and pregnancy. There will be cognitive problems like confusion, negative self-evaluation, insecure feeling, and self-estrangement also. Now, coming to management of CSA, it is a multi-step process and it is a multidisciplinary involvement. The first thing is we have to assess if CSA has been really taken, if CSA has been really done. It is by interviews and history taking, and counseling should be done, not only for the child, but for the parents also. It should be followed by physical examination, psychological evaluation, evaluation for the STDs, necessary investigations, and finally treatment. Treatment should be both psychological as well as pharmaceutical. Follow-up is compulsory in cases of CSA. What are the interventions needed? It can be medical interventions, it should be psychological interventions, psychosocial intervention, and legal interventions also, along with medical intervention, and proper care regarding these 4 types of intervention should be provided by the healthcare professional. But the first priority, please remember, the first priority should always be given to the medical care. When to be counseled? It, as mentioned earlier, it is a multi-step involvement, and the counseling should start immediately on contact with the victim and her parents. It should be during the interventions, and if needed, it should be done during the follow-up after completion of the interventions also. Now, coming to counseling the parents. Counseling the parents is important because of 2 reasons. Number 1, the parents will understand and they will counsel the child and will bring the child for counseling as well as for management. Number 2, it is the parents who can assure and instill confidence in the child after the incident has taken place. For this purpose, counseling the parents is very much important. What are the psychological impact on the parents? First, the parents will deny, but finally they will accept that CSA has taken place. It will be extremely distressing for the parents to know that the child is sexually abused, especially if the perpetuator is a known or family member. The distress will be more. It will start with anger on the self. There will be anger on the self because for letting this incident to happen. They will be frustrated on the child with the misconcept that the child has allowed this to happen. There will be anxious in dealing with the child emotions after the CSA has taken place. If the perpetuator is a family member, they will be anxious regarding the maintenance of relationship with the perpetuator, and they will fear that the CSA may take place again and again if the perpetuator is a family member. And there will be also a sense of loss of family member also, to be frankly speaking. Now coming to the stages of counseling, it's building of rapport, defining roles and boundaries, ongoing support, and closure of the session. It is always advisable to address the parents by name of the parents and use respectable language and neutral tone to build immediate rapport. Looking at them rather than looking at the table, etc., will give an impression to the parents that you are actually interested in what they are saying. Don't stare at them. It will make them feel uncomfortable. Setting aside other distractions like mobile again will increase their confidence in us. Explaining and ensuring confidentiality and reiterating that whatever they say will be highly confidential will allow the parents to open up immediately. Subtle copying the body posture and mimicking their body posture rather than maintaining a rigid and formal posture will help to instill the confidence in them and build a rapport immediately. Allow them to gradually unfold the events rather than forcing them to narrate in a hasty and immediate manner. Now, coming to the second stage, that is defining roles and boundaries. Explain what will happen during the rest of the session so that they will understand that why they are sent to you, what is the purpose, and what is your exact role. Establish their needs, decide what are the immediate and
Dr.
what are the
Srinivas
long-term
Prasad,
needs.
you're just 3 minutes away, sir.
Right, okay. History taking and assessment should be done during this stage. Coming to ongoing support, emphasize that it is not your role, but it is the parents' responsibility to decide the course of action. But you are there as a facilitator to provide them and explaining the options and implications. Assess if they are in right frame of mind. And if they are in right frame of mind and the counseling relationship. But make sure that they feel better compared to the beginning of the session before ending the session. Closure is not permanent, and let the parents understand that they can call back if needed. Now, what is reflection in counseling? It helps to get to the wavelength of the parents. In a conversation, there will be words which you hear, but there will be feelings beneath these words. Reflection helps in getting to these feelings. Suppose you use phrases like, it seems like, I think you may be feeling like. If you use these phrases, you can get exactly to the wavelength of the parents, and you can assure that what you are assuming the meaning of what the parents are saying is true or not. During counseling, just reiterate that all genital lesions and discharges are not sexually transmitted, but genital lesions and discharges can be sexually transmitted irrespective of age and sex. Don't reiterate to the parents not to blame the child. Explain that the doors are always open. The parents can always come back if a need arises. Explain about the POSCO Act. Now, coming to the POSCO Act, which was enacted in 2012, it is mandatory to report to the police or magistrate by anyone who has received information about CSA during professional or personal relationship with the child. It implies that as healthcare professionals, you have to intimate. Before closing, it will be improper and inappropriate to close the session without counseling the child. So what are the main objectives of counseling the child? There are three main objectives. First one is to make the child understand and apply the personal safety concepts. Number two, to enable the child to understand and report the sexual abuse. And number three, if the child is already sexually abused, to empower them to keep themselves safe in the future. In window approach, you will be approaching the child not by directly telling about the sexual abuse, but you will be discussing other topics that are related to the sexual abuse so that the child will feel confident and will open up. These are the various themes that we will be using in window approach for counseling the child. To conclude, HCP should have a keen eye of suspicion and should be apt for counseling also along with medical management. Counseling of parents helps in better management of the child. Let the flowers blossom. I thank the organizers for giving me this opportunity, and I thank all the delegates for a kind and patient hearing. Have a great day. Take care.
Thank you, sir. Thank you for such a clear and lucid talk on a sensitive issue. I request the chairpersons to invite our next speaker, Dr. Bhumesh Kumar, sir.
I take the pleasure of inviting the next speaker, none other than the dynamic Dr. Bhumesh Kumar Katakam. He is an associate professor at GGHEMC, and he has several publications and book chapters and presentations to his credit. He has won several awards and honors in both regional and national fora. His areas of interest are pediatric, allergic and infectious dermatosis, and pediatric HIV and AIDS. And I request him to start his presentation. He will be speaking on how children get STDs. Over to you, Dr. Bhumesh.
Yeah, respected chairpersons, thank you very much for your kind words, sir. So my talk today is how children get sexually transmitted diseases, STD. Before that, we all should know that children are not just small adults. They need separate diagnosis. They need a separate approach for the diagnosis, as well as for the treatment, as well as counseling. The STDs in children are not uncommon in India, though the systematic epidemiological to determine the exact prevalence are not available. They can be acquired via sexual route, maybe a sexual abuse or voluntary sexual activity. Uncommonly, via non-sexual route, such as accidental inoculation by a deceased individual or perinatal. The childhood syphilis, gonorrhea, condylomata acuminata, chlamydia must always be considered in the differential diagnosis. 95% of acquired syphilis in children are transmitted by sexual abuse. That is an area to be noted. The route of transmission mainly depends on the age of the children. The intrauterine or perinatal transmission is more likely at 2 years or younger age group. Between 2 to 10 years, sexual abuse is common, etiological factor. Near puberty, the voluntary sexual activity and sexual abuse. The adolescents mainly, they'll go for voluntary sexual activity because the adolescents, they are neither children nor adults. Always they are for experimentations, exploitations, and subsequently they will be landed into complications. Of course, sexual abuse, rightly spoken by Dr. DSS, I won't go in detail. The Ministry of Women and Child Development, Government of India, conducted a largest national level survey among more than 17,000 children and adolescents in the age range of 5 to 18 years to estimate the burden of sexual abuse, and the results were shocking. It was found that every second child in the country was sexually abused. Among them, more than 52% were boys and 47% were girls, mostly in the age group of 12 to 15 years. Assam reported the highest percentage of sexual abuse, followed by Delhi, Andhra Pradesh, and Bihar. Most common perpetrators are either neighbors or relatives. Most of the abused children belong to the lower socioeconomic group. And important thing is the myth about the cure of sexually transmitted diseases by having sex with children were one of the important factors for the sexual abuse. Children who have sexually abused or exploited frequently suffer from severe mental, emotional, and behavioral trauma. In addition to acquiring STIs, which manifests itself in a social isolation, low self-esteem, and inability to have a normal sexual relations. Child prostitution. So the studies and surveys sponsored by Ministry of Women and Child Development estimate that there are about 3 million prostitutes in the country, of which an estimated 40% are children. The human trafficking, young girls may be victims of sex trafficking. About 7,000 sex workers migrate to Indian metropolitan cities, especially Mumbai, every year, and approximately half of them are minors. They may be sold by their parents, or deceived with the promises of marriage or lucrative job, or kidnapped and sold to brothel owners. Young girls are generally not able to negotiate safer sex, such as condoms, which is very important for the prevention of HIV as well as STDs. A study of HIV prevalence showed that very young girls, the 14 years are young at the time of trafficking, was associated with over threefold increase the risk of HIV transmission related to trafficking at the age of 18 years. And important, the STDs are becoming increasingly common in pre-adolescent age group. The early sexual, because of early sexual maturity, then increase promiscuity, the greater sexual liberation, and sexual offenses are the probable causes. More adolescents are now sexually experienced due to change in cultural and more moral values. The sexual activities generally is very high in homeless street children and putting them at a risk of acquiring HIV infection. And burden of STDs in India, last 2 decades, an increase in the prevalence of STI in children. The various studies resulted represents only a tip of the iceberg, as many infections in children remain undiagnosed due to failure to recognize the problem in this age group. So that's why we need sensitization, we need high index of suspicion in the pediatric age group to search for the STDs. And stigma attached to them, and asymptomatic nature of the infections, and fear of the perpetrators. So these are the important factors. And many healthcare professionals often do not screen children for these infections. In children with STIs, boys usually outnumber 50 to 78%. This reflects the greater possibility of sexual adventures in adolescent boys, increase in homosexual practices, greater attendance of males in hospital compared to females, and of an asymptomatic nature of STDs in females. Only few studies have mentioned concurrent HIV infection. This is seen only in 1 to 5% of all pediatric STIs. The maximum prevalence of pediatric STIs about 2/3 in the age group of 11 to 14 years. This may also point to early onset of voluntary or consensual sexual activity occurring in this group. The homosexual and bisexual behavior increases the chances of acquiring STDs, including HIV, at an early age. Most of these children with STIs are illiterate and belong to low socioeconomic background. Few are from the remand home for juvenile delinquents. The prevalence of homosexuality among the children with STIs gradually increased to 10 to 11%, and a study from Gujarat has reported history of homosexual contact about more than 40%. So the guidelines for the screening for STDs in pre-pubertal children: when a suspected offender is known to have an STD or be at higher risk for STDs, you have to screen. When a child has a signs or symptoms of an sexually transmitted diseases, or when the prevalence of STDs is high in the community, in those conditions we have to screen for in the prepubertal age. And syphilis, the secondary syphilis, the percentage of prevalence of acquired syphilis among all STIs in children has also gradually declined over the last two decades. And the most common presentation of acquired syphilis in children, usually secondary syphilis, most commonly manifest as the condylomata. The lymphadenopathy and cutaneous rashes are other common manifestations, but when you see soft papules, always you have to rule out from, you have to differentiate it from condyloma acuminata clinically and lab-wise. And the gonorrhea, like other bacterial STIs, has shown declining trend, as spoken by with many speakers. And this is a 17 years male adolescent, the history of unprotected sex with a known person. After 5 days, the classical presentation of purulent discharge. And the prevalence of chancroid in children with STIs has also decreased dramatically. There is no data about donovanesis in children. And when you diagnose, you have to treat accordingly. I won't go detail, and it was discussed elaborately in previous sessions. Viral STIs have shown an upsurge in the recent past in that genital herpes is the most common the STDs, and followed by condyloma acuminata is another important viral infection. And this is a child. The history of genital ulcers 1 week back and history of exposure, the vesicles on upper lip 5 days. And the features are not classical of genital the herpes, but for the we have done the jonc, there is acantholytic cells from upper lip, and even the HSV 1 and 2 was positive, and we have treated accordingly with acyclovir 20 mg per kg 4 times in a day over a period of 7 to 10 days. After that, it was subsided. When you see the anal warts, perianal warts, always we need to remember whether it is abuse, sexual abuse, or any accidental inoculation, or active sexual activity. So these are the 3 important areas. In these 2 children, based on the history, there is history of sexual abuse. Once if you label any, whether if you see the genital perianal or perianal warts, once if you rule out the immune status, the next step is how to clear the lesions. Whether to go with the medical therapy or surgical therapy. And an important thing is when you diagnose sexual abuse, rule out immune status, and the counseling part is very, very important in the pediatric age group. Always in my practice, I will follow the instructions of the formula of M square. The medicine as well as the mind, that is a counseling. The counseling, pre-adolescent counseling is different and adolescent counseling is different. Medicine, as a doctor, my role is 50%. As a mother or a caretaker, if it is a pre-adolescent, you will need to involve the caretaker or mother, because the pre-adolescent children, they won't take care of themselves. Whereas the adolescent, they won't follow the instructions of anybody, whether it's a mother, father, or a doctor. You involve them. Unless until you involve the adolescent, so the treatment is inadequate. So this another child, sexual abuse, HI was non-reactive. So after 2 injections of MMR in Gandhi, we have done a study with myself, Dr. Neta, and Rajiv Singh all. So this is another important immunotherapy. When you initiate the role of immunotherapy, especially MMR, you have to label the child should be immunocompetent, and if the lesion is perianal, so this is one of the important options. It should see that it should go to the intradermal levels to stimulate the dermis and subsequently the immune system, that will clear. This is the MMR vaccine. It's a powder form. It has to be distilled. The distilled water has to be added. One thing we need to remember: this is it's a live vaccine. So once if you give live vaccine, so the cold chain is very, very important. So if you won't maintain cold chain, the treatment is just like it won't help at all. So and the dilution.
Dr. Umesh, sorry to intervene. You're 3 minutes away, sir.
Yeah. When you are diluting, so don't shake the vial. Just you rotate it, and you have to give the cold chain, and the dilution is very important steps. And mixed infections are not uncommon. So to conclude, the antenatal screening of all women should be carried out, and if found to be infected with STIs, they should be treated adequately to prevent the perinatal transmission. The congenital syphilis is a preventable disease. Even every case of congenital syphilis indicates towards failure of maternal and child health services in the country. The STDs in children are a worrisome problem. So always they need high index of suspicion. The diagnosis of an STDs in a prepubertal child must raise the concern for the possibility of sexual abuse, and it has to be evaluated. And subsequently, it has to be reported. And the prevention and treatment of adults are the main step to prevent these infections in children, because the child abuse is one of the important factors for the STDs in the pediatric age group. The comprehensive sexuality education should be every child's right. It's the birthright of child. So psychological support should be provided to the victims. Health education along with the behavioral therapy and regular screening is required for high-risk groups like street children and children at work. So stringent laws against sex trafficking and child labor has to be implemented. and it is important to improve the awareness among children, parents, and adolescents and general population to decrease the incidence of sexually transmitted diseases in the pediatric age group. So finally, take-home message is always the healthy penis is healthy vagina and subsequently healthy skin, so then the healthy body and healthy nation. So the awareness and counseling should be started regarding the sexual health education should be initiated from the pediatric age group. Subsequently, we can prevent the complications and decreases the chances of sexually transmitted diseases. And I request all because we are seeing almost more than 1,000 PGs are participating. I request all PGs, please look for and sensitize for healthy skin and healthy sex, subsequently healthy body and healthy nation. So please sensitize another 10 people. So for for healthy skin and healthy sex. So thank you very much for your kind attention. Thank you.
Thank you, sir. Thank you for an excellent presentation. We'll now move on to the panel discussion. I request the chairpersons to introduce the moderator, Dr. K.A. Sitaram, sir.
Thank you, Sirisha, and thank you, organizing committee, for giving this opportunity as an chairperson. Now is the time for the panel discussion. The moderator for the panel discussion is Dr. A. Sitaram, sir. He is the professor, Department of DVL, GSM Medical College, Rajahmundry, and he is a state medical registration. There's a lot of publications and a lot of achievements. He is a reputed national, international dermatologist. He has a lot of publications, and he has been with a lot of guest speakers and a chairperson, moderator, and has conducted a lot of quiz programs, and has contributed a lot of publications and to the author for so many textbooks. And he's one of the most reputed dermatologist practice for more than 3 to 4 decades. I take the privilege of introducing Dr. Sitaram, sir. And the topic for today's panel discussion is sexual, non-sexual genital issue in pediatric genital dermatosis and vaccines against STIs. Now I invite Dr. Sitaram, sir, to come onto the dais and introduce his moderators, introduce his panelists to the session and start the session of panel discussion. Over to Dr. Sitaram, sir.
Thank you, Madhu. Thank you very much. Good afternoon. Okay. So can we see the screen?
Yeah.
Okay, right. So good afternoon, everyone. Thank you very much for the ASTICON team, ASTICON 2021 team, especially Dr. Nrsimha Rao Neta, Dr. Bhumesh Kumar, for inviting me to be here as the moderator today. And the excellent sessions are going on since morning. So with a lot of messages in each session. So the PG quiz was really innovative. The students are very much interested. So that's wonderful. So coming to the panel now, so it's mainly the pediatric genital dermatosis, both STI and non-STI, and then something on vaccines. So we have extreme panelists here today, Dr. Rajiv Sharma, Dr. Vihu Mendarita, Dr. Sridhar Janjhala, Dr. Resham Vasani. Unfortunately, Dr. Arun could not join us today because he has some unexpected emergency issues at the university, as is the Dean of the BLD University, Bijapur, so he could not make it. And Dr. Rajiv, my close friend since the MD days, and we all know him as the past Honorary Secretary General of IADVL, and he has conducted the International Congress of Dermatology at Delhi, and he is the consultant dermatologist with a lot of publications and of course numerous presentations, and he has received the Professor D.B. Chandra Memorial Veneration, Dr. K.N. Saxena Memorial Veneration, and then he had worked as the president of Indian Society for Pediatric Dermatology, and very lot of special interest in the pediatric dermatology, acne, and pigment disorders. Welcome, Rajiv. And we have Sridhar Janjhala. He is working as the professor and HOD at the Dermatology INHS Ashwini, Mumbai, and he has a number of publications, and is a member of IADVL Task Force Against Topical Steroid Abuse. He is a reputed editor at the Indian Dermatology Online Journal, and he has delivered the Silver Jubilee Oration of Institute of Venereology at ASTICON 2016. We have Dr. Vibhu Mendiretta, we all know her, and she is the head and director professor at Lady Haydn Medical College with more than 160 publications and numerous presentations. And she received Commonwealth Fellowship, Pediatric Dermatology, and the Developing Country Dermatologist Award in 2007, and ICMR Fellowship in Pediatric Dermatology, WHO Fellowship, and then Founder Secretary for the Society for the Pediatric Dermatology Delhi, worked as President, Delhi State Branch, and received Sardar Lal Memorial Oration Award in 2015. Welcome, ma'am. And now the young and dynamic lady, Dr. Shimosani from Mumbai, and she is a consultant to the various hospitals at Mumbai, and a lot of publications, nearly 60 publications are there. She contributed to 14 chapters and numerous presentations. She has the Das Award of Excellence Dermatology in 2019. She is an assistant editor and on the editorial board of various journals of the IJDVL, IJPD, IDAJ, and she is a member of SAG Pediatric Dermatology, and she worked with us as a member of IDVL Academy during 2016 and 2017, and winner of the National AMLA MD Gold Medal, and a lot of international scholarships. Welcome, Dr. Resham. So I hope all of you are there.
Yeah.
I could not see the people. Right. Okay. So basically, we will go with a few case-based discussions, and then some take-home points are based on that. And okay, let's see the first case. This is a case of a 9-year-old male with whitish urethral discharge for last 3 days. There is no foul odor, there is no burning nutrition, and there is slight, mild, well-demarcated erythema over the shaft penis. You can see the next slide. See this here, and there is mild erythema here and the shaft penis, and then this whitish cheesy discharge, superficial discharge. So how one should approach? This is a patient of 9-year-old male. Anyone? Dr. Ma'am, would you like to take it up?
Yeah, so hello, Dr. It's a pleasure to be here and on this platform. So you said that it's a 9-year-old boy who presents with this whitish discharge, and there is no history of any sexual exposure or any sexual activity or any abuse. So I would like to actually first rule out any STI, associated STI, because the idea is that any involvement of the genitalia in a young child, we must always exclude possibility of any sexual exposures and any sexually transmitted infection. Now, with this particular case, as the discharge seems to be subprepucial discharge,
yes.
So subprepucial discharge. So we will like to see this, and this could be. We have to, retract the prepuce and see from where the discharge is coming, and we have to ask in the history, any history of dysuria, burning micturition, or any other associated complaints. So if there aren't any, so subprepucial discharge generally is due to the poor hygiene in this age group. So it is because of the collection of smegma which gets collected, and that needs to be cleaned up, and one must counsel the adolescent and also the parents regarding the need for regular cleansing of this area by retracting the prepuce. So and in case, so there is redness also. There could be some associated, because collection of smegma can give rise to secondary balanoposthitis.
Yeah, so, this redness is because the history when we are taking, this is nothing but they have applied some Jendu balm because there was some swelling there and the shaft of the penis because of the collection there. So they applied the Zindu bomb. So that was basically the erythema produced by the irritant part of it. Irritant part. Yes. Yeah.
So,
Rajiv, would you like to add something?
Sir, in history, first of all, I'd like to know whether there was some phimosis initially or not, whether the parents were regularly clean, because it is how you want to know the approach.
Yeah.
So if there was phimosis, then whether it was being cleaned or not. And this subprofusal discharge appeared suddenly, or it appeared over a period of time. And of course, Dr. Vivu has mentioned about the sexual activity and sexual habits of the child. But still, since there is no foul smell or there is no irritation, it is less likely to be an infective process per se. It may be secondary to something like smegma she has mentioned, if it has been retained for long. That could be one of the reasons. So the examination part, again, retracting might be painful at this stage for the patient.
Yeah, we did.
You have to handle with care.
So that's what we did, Dr. Rajiv. We tried to retract the things and cleaned all the discharge seen around. And that's only one point. At one point, we were able to see that white cheesy material coming out. The rest of the thing is clean, and there was no discharge from the urethra as it is.
So it's smegma pearl or something like that.
Yeah,
smegma
that looks like, I mean, there is no foul smell as I mentioned. There's only a whitish cheesy discharge coming like that. And then if you go after 5 days, so the entire thing completely subsided, including the erythema or by producing Jindulbam, even that has gone away. So that is no discharge at all. The only advice we gave was just retract and clean as much as it comes every day, 2-3 times a day. So that was completely the discharge subsided and there is nothing. So that's true that as Dr. Fu and you said that it looks like only a smegma, but only thing is producing such a, huge subprofusal discharge, large amount. Morning also I heard from Dr. Rajiv Singh's panel, smegma producing the concretions, collections like stones, and they have shown 2 cases, and then the melanocytes also. That's true. Here also again, another case, we are seeing that with a lot of subprofusal discharge, there is no foul smell, there is no burning, there is no irritation, except that the discharge was there for last 3 to 4 days. So that was the thing. So the only entire idea is bringing that is, and of course we all know this is white cheesy material without any foul odor, and the smegma pearls and smegma stones. It forms like concretion, sometimes very hard, and these stones can produce the melanocytes also. So this is one of the reference article saying that the smegma can form these stones in that. And right, is smegma carcinogenic? Sridhar, would you like to comment on that? There are some statements, some made, some myths.
Smegma is a physiologic discharge. It's unlikely to be carcinogenic, sir. The fears of the parents, etc., on this ground should be allayed, because there is no real risk of carcinogenicity of smegma. It's just a collection of epithelial cells with some inorganic stuff. Hygiene and as has been brought out by the other panelists, hygiene and regular cleaning, and if there is any phimosis, correction of that, these should be emphasized. There is a chance of recurrence of this.
Yeah, so that's true. As you said that, so there's a lot of studies are there saying that there has no role at all. It is not at all carcinogenic. Just to emphasize, we say that this is not carcinogenic. So the message is that all the subprofusal discharges are not STIs. The smegma, a collection of epithelial cells, can cause balanitis sometimes, and a proper hygiene, regular cleaning, and a counseling to the parents are essential in this. And then smegma is certainly not carcinogenic. Anybody would like to add any comment in this? Yes. Yes,
I would like to add a small comment here.
Yeah, please.
That although it is been, the myth has been busted that it is not carcinogen. I was reading somewhere that smegma may be associated with the development of lichen sclerosus heterotropicus, LSCA, I think. So which is again, so I think like all triggers which give rise to chronic inflammation or chronic infection, they are responsible for inducing some dermatosis, and LSCA could be associated with long-term smegma buildup.
Right. So indirectly, if you want to say that, yes, there was a discussion that was in the morning. Smegma in the long-term collection, if they are not properly cleaning, it can induce lichen sclerosis. Yes, that point was very well taken. So but in general, normally it is itself is not carcinogenic. Okay. Yeah. As
Sir,
we
can I
got
make
out
a point?
Please.
Sir, Sitaram,
Please,
sir,
Rajiv.
can I make
Yes,
a point?
Rajiv.
Because
Rajiv, yes.
we are discussing smegma only in men or males. It does happen in females also.
Correct. Yes.
So it is important both male and female children should be taught how to clean.
Yes. Would you like to say something more on that?
Sir, the cleaning of the labia is as important and the clitoral hood is as important in females as it is the cleaning of the subpreputial area in the males. So, and it is said that retraction of prepuce should not be attempted very early in life. It should be started only when the child is 4 or 5 years old, because it is only then the retraction becomes easier. But the Indian tradition, I think, is to retract it much earlier. So I think our teaching should change.
Yeah. Taken. Well taken. Your point is it is both there in the males and females. We should conceal both the sexes with the parents. Yes. So let us go to the case 2. So of course we all know this is lichen sclerosis. So this is because we commonly see, but again, a lot of issues in the management and a lot of problems about the confusion about the vitiligo. So let us share some knowledge about how to differentiate it clinically from vitiligo and how to manage this. Is there any risk of malignancy in this, in children especially? And does it resolve? All these cases, does it resolve at puberty? So these are the 4 things we try to answer. Dr. Resham, would you like to say something?
Yes. Lichen sclerosis, to differentiate it from vitiligo, both of them look depigmented. But on the history, there will be history of associated itching, associated pain, dysuria, and constipation is a very important symptom in the pediatric age group especially. If we go on to the clinical examination in patients with lichen sclerosis, we would definitely see, many a times we see that figure of 8 pattern, which is lacking in vitiligo. Also, architectural disturbances in terms of sometimes the burying of the clitoral hood, eating away of the labia minora. That is a thing. Architectural disturbances are what are seen in lichen sclerosis, while these are absent in vitiligo. Also, when we palpate the lesion, the induration of the sclerosis is much more appreciable in an evolved stage of lichen sclerosis versus the smooth and the soft skin in patients with vitiligo. Nonetheless, we should be aware of a fact that there is an entity which is called as vitiligoid lichen sclerosis. Now, in these patients, they may not be as symptomatic as in lichen sclerosis, but on histopathology, they definitely show evidence of lichen sclerosis in terms of the band-like infiltrate, the atrophy of the basal layer, and deposit and the collagenization of the dermis. So I think that is one thing that we should be aware of.
Are you also, I think, a dermoscopist? Dermoscopy, does it help in differentiating these two? Yeah.
Yes, sir. Yes, sir. It does. In patients with lichen sclerosis, we may see white homogeneous areas. Sometimes we may see follicular plugging, telangiectasias. While in patients with vitiligo, we will be able to see sometimes the milky white areas associated with evidence of repigmentation at a few sites.
Yeah, so we have a lot of features to differentiate both vitiligo and the lichen sclerosis, as Dr. mentioned. Yeah, Rajiv, please. Rajiv, go ahead.
Apart from what Dr. Resham has said about the vitiliginous LSA, the repigmentation also occurs faster in those patients who have got an overlap of vitiligo and LSA. And they tend to heal like vitiligo lesions, even though the histology is that of LSA.
Okay. Right. Sridhar, would you like to add something?
Yeah, one point I'd just like to add regarding the clinical assessment. The Fordyce spots, for example, here in the margins, we can see certain, possibly, physiologic sebaceous papules called Fordyce spots. These would be conspicuously absent in the sclerosed area of lichen sclerosis, whereas they could be present in normal vitelliginous skin. So the vitelliginoid LSA is more of a vitiligo with some features, which is probably a Keebnerized vitiligo because of the irritant response of the urine and the acidic secretions. So the differentiation is very critical. If we can home on to LSAT early in the course of this thing, we can do a world of good for the patient. Dermoscopy with saran wrap showing follicular plugging, as Dr. Resham has said, that more or less clinches this thing. There's very rarely a need for a biopsy.
Okay. Dr. Vibhu, you have some publications on this. Would you like to say something? Yeah, please.
Yeah, I would like to just add here that early diagnosis is really very important, and early diagnosis is difficult because here the picture that we see here is something which is already evolved into a sclerotic and atrophic phase, because we can see that the skin is tight and the labia minora, and they seem to be little atrophic, and there is a fusion taking place, and there is erythema. There can be some possibility lenses. Yes. So these are the signs which are of the advanced stage, sclerotic atrophic stage of LSA. So here, but the right stage or the critical stage at which the diagnosis has to be, made is early stage. And early stage, again, we have to do dermoscopy, because clinically it may not be possible. You may palpate if the lesion is not well, the extent is not this big. A figure of 8 comes very late. It may not come many a times. The child will be symptomatic. What I have seen in this thing is that in vitiligo, it is just the parent who notices and the white spot. And if the child, the parents would notice that the child is symptomatic. There would be itching, there would be burning, there would be, if the child is able to, like a young child. So sometimes there is burning, there is constipation, there can be dysuria. So again, this awareness has to be given to the parents that this can happen. So early diagnosis is high index of suspicion in any white spot disease there. Dermoscopy must be done in all cases who are presenting early. Palpable, we must palpate the lesion, because the textural changes can only be appreciated if we palpate and touch the lesion. Right. So that is what my take is.
So well taken. So the clinical examination is very, very important. Just feel the lesion, palpate it, see is there any induration, and everything is there. Of course, the erythema will be evident, and the architectural changes, the patient has mentioned it. And dermoscopy, yes, certainly plays a good role if you are in suspicion. Now, what is your first choice, Rajiv, to treat this patient?
Should I answer?
Yeah, go ahead.
Yes. No, so if potent steroids, I'm not using super potent. So for as far as I am concerned, I am only using betamethasone valerate. Up to that, I'm not using clobetasol. So I'm using that for a good period of, say, 2 to 3 months, regularly, twice daily application, along with an emollient, usually a vitamin E preparation. And then once the skin becomes, there are changes in the texture, it is no longer hard and the pliability is better, then I step down to tacrolimus for another, maybe say 6 months.
Rajiv, do you differ anything? Will you continue the same?
Yeah.
Please.
I try to start with a super potent steroid for about 2 to 3 weeks. Then I step down to mometasone or fluticasone, and then I switch over to tacrolimus.
Right. So I also start with the potent steroids, certainly, and then slowly, as ma'am said, we will lower it down, tap it down. Okay, Resham, what are the chances of malignancy in children in these patients?
The risk of malignancy with pediatric lichen sclerosis is up to 1%. Hence, it is very important to counsel the parents and the child for a regular follow-up. And ideally, the follow-up has to be at least till puberty. And 75% of the cases, they also show symptoms after pubertal age. So it's important that they are counseled for a regular follow-up. We monitor them for any evidence of any ulceration, any hyperkeratotic plaque, any other evidence of any malignant change. And ideally, the monitoring is for a lifetime.
So it's usually less common compared to the adults, but definitely a follow-up is required. So, yeah, this is the thing, that depigmentation, constipation, dysuria are more prominent. And if it is the triggers, nocturnal enuresis, urinary incontinence, and sexual abuse are the common triggers in children. And hymen is affected if it is a sexual abuse, but not routinely in the LS. The vulvar squamous cell carcinoma is uncommon in children compared to the old age. And it may not resolve at puberty usually. So the residual signs still, they may persist to the thing. This is one of the articles which we published in the IJPD, the vulvar lichen sclerosis in children. The prospects should be over 3-year period. And we have seen around about 25 for NS and 186 were having the LSA. And these are the predominant symptoms. Again, depigmentation. The figure of 8 appearance, as Dr. Guru said, that's seen in only 4 out of 25. It's not that common. It was seen, but it is less. And topical potassium steroid was the mainstay in that. So this is the vulvar message is the itching may be there and figure of 8 appearance may be present. Topical potassium steroid is the mainstay. SSC is uncommon in children and it may not resolve at puberty. Okay, let us go to the case 3. Yeah, Raju, would you like to say anything?
Yes, sir. Sir, the importance
Please.
of occlusive undergarments has been published in some papers should always be made. Children are using very tight undergarments, tight clothing, and that somehow prolongs the course of LSA also.
Right.
And Dr. Somesh, I think, has published something on this in a journal. So that should be a part of management strategy.
Counseling, yes. So thank you for bringing that. This is another case contributed by Dr. Resham. Dr. Resham, would you like to talk on this?
Yes, sir. So this was a 6-year-old girl, and as we can see, she had warts over the inguinal area. The reason why she came to me was the intense pain and multiple ulcerations and erosions on the inner aspect of the labia majora, as well as involving the labia minora. And the pain was severe enough to for her to go into urinary retention for around 16 hours before the patient presented. And as per the history, the parents were applying topical imiquimod over the warts, which was prescribed by the dermatologist. And as per the history, they were precisely applying the cream only over the affected areas. On the rest of the examination, the oral cavity palm soles was absolutely normal. Non-tender inguinal lymphadenopathy was present, and there was no history of any preceding vesicular lesion. So looking at it, the first impression was herpes genitalis. So to rule it out, we did a Zank smear, which came out to be negative. Also, the other members in the family, the mother, the father, and the caretaker were examined, and the female caretaker, was found to have warts on her palm. So that explained the heterologous transfer of the HPV virus causing the warts on the inguinal area. And there was no other evidence of any sexual abuse. The HIV, VDRL, HPSC it was completely negative, and the antibodies were also negative for HSV. So at the end of the history and the examination, it was thought that imiquimod, which was being applied for these warts, was actually the culprit, and this was a kind of a paradoxical distant site reaction because of imiquimod. The explanation that is given in the literature is that whenever we apply imiquimod, 1% of it gets absorbed into the skin. Now, when we are applying it to a inguinal region of a child, the absorption is likely to be higher. Also, it would take around 15 days for the imiquimod to achieve a concentration in the serum. Now, this imiquimod is further acting upon the toll-like receptors which are present over the mucosal areas, and this leads to the infiltration of the leukocytes and consequent mucositis and ulcerations. As we can see, intriguingly, wherever the imiquimod was applied, that area is completely normal, and majority of the inflammation is only on the area of the mucosa. So that is what was interesting.
Yeah, thank you, Dr. Resham. It was really interesting. So, I have not seen any other panelist. Have you seen like this or any comment to be made on this? Imiquimod inducing the ulcers.
Yeah, not in the perigenital area, but for molluscum contagiosum on face, there have been children who have come with oral ulcers. I have seen 2-3 patients who have done.
You have seen? Okay, great. Yes, I was just coming to that. There are a lot of reports. I mean, the people who have applied on the molluscum contagiosum developing on the ulcers. That is true. So these 3 questions have to be answered. There is no answer, I hope. Why is it not occurring on the sites applied, and why is it occurring at the distant places? And why only mucosa? Why not the ulcers at the other cutaneous parts? And why only mucosa? Any insight into this? Anybody, any thoughts? But I could not find any answers in the literatures for this. So the pathogenesis of the ulcers, Dr. Resham has already pointed out. So these things are still unknown. And these are the various reports. The oral ulcers, I mean, after 5% imiquimod treatment in children. And so this is one case documented in the pediatric case group also, but adults, there are many. In the children, it is only one case reported so far. And the distant mucosal lesions appear to be a rare and underreported side effect. After ulcers, erosive colitis after imiquimod for facial warts and molluscum contagiosum is known in adults. So no alteration of the application sites, and definitely a close vigilance of the adjacent and the distant mucosa is recommended. And we all should be aware of such a potential side effects so that we can stop the imiquimod, and so the patient will improve without unnecessary other treatments being given to them. Yeah, Raju, would you like to want to say something? Right. Okay. No. So that's about the imiquimod. Certainly interesting. Thank you, Dr. Resham, for contributing that. Yeah, this is a 16-year-old obese having these type of lesions, multiple sinuses and nodules for the genitalia and the axillae for last 3 years, and they are recurrent. And that's partial improvement with the antibiotics sometimes. And yes, we thought of hydrogenated suppurativa because the perineal genital involvement and the axillary involvement are there. Chronic duration, 3 years, recurrent, painful, multiple nodule sinuses. So we thought of hydrogenated suppurativa. So how do we approach this case? Sridhar?
Yeah, the diagnosis of HS seems to be fairly certain in this case, and it all depends upon the staging. The early stages, 1, 2, and 3. This particular patient appears to be falling into either stage 2 or stage 3. Now, stage 3 is interconnecting sinuses. That needs to be ascertained on clinical examination. So stage 2 to stage 3 in an adolescent girl. Firstly, we look at any other comorbidities which are already there, and I think in this case you said she is obese.
Yes.
So management of these general measures, that is your management of the risk factors, metabolic syndrome, etc., etc. These have to be looked for and managed. Counseling, of course, this is going to be a lifelong condition or a long-term condition, and that needs to be done. And thereafter, the definitive treatment will depend upon the stage of the disease. In this case, and since it's stage 2, I would go for a course of antibiotics, possibly clindamycin or augmentin-based.
Do you consider tuberculosis at all in this patient?
Yes. See, the presence of sinuses, one is extragenital Crohn's. This is the one possibility. Those knife-cut ulcers, this is a classical description, extragenital Crohn's. Crohn's is again very closely related to tuberculosis. Tuberculosis, yes, but she has got already, you mentioned, sir, distant site involvement in the form of axillary involvement in an obese girl with presence of multiple sinuses. Tuberculosis definitely has to be ruled out prior to.
Yeah, that's right. So just I want to make that point very clear, Sridhar, because so we had seen one case, similar case, not this lady, but having these lesions in the both axillae and the genitalia, thinking that it is HS. It was treated for a long time, and finally, when a biopsy was done, it proved to be a scrophloderma, and the PCR was positive. Finally, labeled as a multicentric tuberculosis. So it's possible in our country. So I think we should not underplay the tuberculosis in any case. Definitely, we should rule out that. And of course, anyway, this is certainly HS. Are there any differences between children and adults in HS, either in presentation or in treatment approach? Dr. Resham?
Yes, sir. The presentation in children, we see that it is more commonly associated with obesity. Smoking per se is not as common to be a contributory factor in hidradenitis suppurativa in a child versus an adult, though passive smoking is definitely attributable. Further, if the age of onset is earlier, the chances of it becoming a chronic and a more severe presentation is more likely in children versus an adult.
Okay. Rajiv, would you like to say something?
Same, but I always think that we should always keep in mind hypothyroidism.
Okay.
We always overlook that and we think only of about diabetes and obesity.
Yeah.
Hypothyroidism may be equally important in such patients, and passive smoking in a smoking family can happen even in young children. So that should also be kept in mind. And in children, weight reduction, if possible, helps to a great extent in helping these lesions to resolve earlier. If they are picked up earlier, at this stage, it may not be very helpful, but if they are picked up earlier, they do work wonders for them.
Dr. Vibhu, you have a publication on this here.
Yeah, so first of all, I would also like to, add here that pediatric HS generally is seen, usually there could be a possibility of a family history, some genetic predisposition can be there. So other than obesity, it gives us an opportunity to, screen the child for associated polycystic ovarian disease. That is, I have seen in 2-3 of my patients, adolescent girls. Obesity is important, diet has to be looked at. Then the metabolic syndrome, some of them do have, insulinemia, insulin resistance, it may be associated with. So that basically gives us an opportunity to screen the system for all the underlying metabolic derangements that may be associated with obesity. And also smoking is not common in pediatric age group. So certainly exclusion of tuberculosis is very important, and then lifestyle modification is the first thing, and that we have to, and we also have to counsel them regarding the hygiene measures, weight reduction, avoidance of tight clothing, taking a diet which is rich in polyunsaturated fatty acids, and reducing the intake of saturated fatty acids, controlling their blood sugar. Physical activity is very important. You have to encourage them. Yeah,
Yes.
exercise, physical exercise.
Correct. So that's the most important. So we only in children, you may have a positive family history. The obesity may be more, and the metabolic association of the comorbidities are much more when compared to the adults. So that's the main thing. And the treatment anyway, the general counseling, general measures, Dr. V has pointed out, that's very, very important rather than the pharmacological treatment. And of course, we have stage-based treatments and we all do that. But the importance is the counseling and the general measures, as Dr. V has pointed out, that should be our first line. So the pediatric HS is not that common, and if there may be a positive family history, the comorbidities are more, and obesity is more, and smoking component as the age group is, it is less. And the topical oral clindamycin, rifampicin, and biologicals are the treatment of choices along with the general measures. And finally, at the end, maybe the partial or the complete excision of the entire area. Yeah, this case is only for discussion. I also don't know the diagnosis. Let me be very frank in this. See, the 6-year-old boy started these lesions during his second year. There is no diarrhea, and lot of investigations were done, including the endoscopy. There are no malabsorption syndromes. You see the other figures also first. He has these lesions also elsewhere around the nasal and the perioral, hands, and the joints also. And endoscopy, there are no malabsorption syndromes. Serum alkaline phosphatase was normal. Serum zinc was normal. And despite that, because of the distribution and everything, we thought clinically it's only acute dermatitis enteropathica, and the zinc supplementation given even with the higher dose, more than 3 micrograms per kg, 3 mg per kg per day, and he did not improve. So despite that, for months it was given before me and with me also, but it did not improve. So how to go? Any comment, anyone?
Sir.
Yes, Sridhar Raju, please go ahead.
Please, sir, go ahead.
Sridhar, sir, please continue.
Sir, please go ahead.
Okay, I was saying we don't have a real glazed appearance of the skin and we don't have diarrhea. So acrodermatitis enteropathica or zinc deficiency would not come to mind. I would think if a presentation with this type of onset at 2 years of age, did the patient have any neurological symptoms or any hearing loss?
No. No,
Any
nothing.
hearing loss
Otherwise,
or neurological
otherwise his
symptoms?
milestones were very normal. And when
No,
he
but
came to
hearing
me,
loss.
he is 6 years old. It started at second year, but he's at and he came to 6 years old. And at this point of time, he was very fine.
But sir,
Milestones were
hearing loss,
normal.
we
He
will
was
have
going
to do.
school. Yeah.
We'll have
I
to do
didn't do.
audiometry. Audiometry
Okay.
should be done because if
Okay.
there is hearing loss,
Okay.
then we can think of multiple carboxylase deficiency or biotinidase deficiency.
Okay.
We can think of these two conditions which are rare, not so common probably, and we often don't even have the facilities to work them
Correct.
up. But
Correct.
this type of presentation in some journals are there of such cases.
Okay. I didn't do
but they
hearing
do
loss.
have
I will do.
neurological problems.
Yeah, I will do. I will do. I have not done that.
Neurological
Yes.
problems.
Okay.
Neurological problem and assessment of these enzymes can be done. Though biotin assessment is not very common, but the
Yes.
biotinidase and the carboxylase things can be done in some
Can
labs.
be done? Okay. Sridhar, you want to say something?
This definitely appears nutritional, sir, some way or the other. Zinc is the most obvious go-to diagnosis. But still, if it is not zinc, then we have to go look for the other nutritional disorders as brought out by Rajiv, sir. In fact, the hand lesions look something like a pediatric, like Hartnup, you know, the pediatric version of pellagra. But then covered sites. So it could be also a multiple etiology of nutritional deficiency where multiple nutrients are deficient. Sometimes trace elements, magnesium, these also can produce perioral lesions. So these have to be looked into, sir. Very rarely, of course, if it's very long-standing, then we have to look at those, pemphigus, because there are some serpiginous lesions, especially in the margin of the pemphigus vegetans type of lesions. But
those were done. Yeah, those were done last year. I did not know all those things because of time. Those are all the investigations were done. Everything
Correct.
was excluded. Yeah, including the immunofluorescence studies, histopathologies were done, and nothing was coming out. So, as Rajiv has pointed out, could it be a biotin deficiency? We were, in fact, so we gave him along with zinc the other nutrition elements, as you pointed out, which contained biotin also, and he improved on that. Let me show you the. This is the clinical improvement when we give him the added the biotin. So at that time, we never realized it is biotin deficiency. But with the zinc, when we added the other nutritional compounds which contained biotin, he improved like this. But whenever I stopped that nutrient and continued zinc, again he developed this. So then I thought, could it be only a biotin? Because whenever we were giving biotin, he was improving it. I tried to find out whether we do
Dr.
biotin.
Sitaraman, I'm sorry, you're just
right.
5 minutes away, sir.
We are completing, no problem.
Thank you.
So that's how could it be biotin. So we tried to find out whether it is. Anyone can do biotin estimation, but as Raju said, that it is just not possible. And that was something interesting which you had seen in this case. And he is still on biotin. And whenever I reduce the biotin and I stop the biotin, it completely comes back. Zinc I have stopped, and he's still only on biotin. Yeah, Raju, please.
Sir, this is very typical that if you administer biotin in biotinidase deficiency or multiple carboxylase deficiency patients, they improve.
Yeah.
So this dramatic response is seen more in these patients. The biotin levels, in fact, may be normal. The enzymes are lacking.
Is it available? Can we do that testing?
Yes, sir. It can be done. I think you can inquire from the labs.
Okay, fine.
It can be done,
inquire
sir.
from various labs.
It can be done.
Vibhu, yeah, please. Where is that? Is it available?
We send our samples to the metabolic lab we have at Maulana Azad Medical College in the pediatrics department. Okay. So the biotinidase estimation is done there, and plus, the levels will be mild deficiency, moderate, and severe deficiency. So what the picture that Rajiv was talking about is for the severe, deficiency where they will have convulsions, seizures, and a neurodegenerative picture with severe seborrhea, stunted growth. But this child seems to be, otherwise overall normal. doesn't have any seborrhea, just has.
Yeah, that's right.
So,
So thank you. We will get it done if it's possible. Yeah, Raju, please.
Multiple carboxylase deficiency should be kept in mind. It
Okay.
has varied presentation of different severity. Even
if it is available there, we will,
deficiency varies in individual. Yeah, sir. Even somewhere in down south in a good metabolic lab, these things could be done.
I didn't think of the enzyme levels as such, but I inquired by team, but it was not possible. But now, okay, based on your inputs, I will look into that.
Dr. Vibhu is always there to help
yeah,
to
I
get
know.
it done.
Thank you very much for pointing out that. So this was, I thought I'll just share with you, and this is what is happening. Improvement with only by team. Right. So because we have STA vaccines also in our part, and just the last two questions. So these are the two things I think specially practiced. All others are in experimental only. We all know that all the vaccines are available here, and this is the Indian journey. Most of us know. So started from 2008 and till 2019, various steps are there, including the IARC study and the HPV vaccine. 2 doses versus 3 doses. That was the IARC study. Sridhar, would you like to say something? Because you have presented also this last time. And
yes, sir. Most certainly, sir. This is one of the few viral vaccines which we have against STIs. That is one is HPV and HPV. And HPV has vaccination has been dramatically successful in the West, especially in Australia, etc. In India also, it is taking off. I advise it to all the young girls who come to my ring. I have a daughter. I have vaccinated her as well. She's just 11, first dose taken. The point is the number of doses. The American guidelines recommend just 2 doses, and I think which are followable in India, considering the cost. And the vaccine which we can go to is the Gardasil vaccine. So that's available. It's costly, but that is recommended. If you can have the.
Is it the same price? It's mentioned here. Is it the same or something more?
Sir, it's increased now.
It's increased now.
Yeah, sir, it's actually for Gardasil, it is 3,570 is the MRP.
Okay, fine, right. So anyway, all others are in experimental stage. So nothing much to talk about those things. And HIV is another one. So the 2 vaccines are in practice, HPV and HPV. All others are in the preclinical stage. Yes.
Yeah, regarding this HPV vaccine, it's a high time to sensitize, because in IAP there is a lot of awareness and sensitization, and the age is very important. At 9+ is the ideal age to initiate the vaccination, because once this virus enters, the efficacy may be there, but not up to that mark. So 9 to 14 years, 2 doses with the gap of 2 months is ideal. That will give the sufficient 100% protection for the warts, but even more than 95% for the cervical intraepithelial. Even though if it is more than 14 years, we can give a booster dose with a gap of 4 months. What we are practicing regularly in a month, 4 to 5 cases I'll give. The thing is, the Gardasil, when you are giving the vaccination, always please keep that child in a lying down position. After that, let the baby or parents will be there in our clinic for 30 minutes.
Okay, thank you, Bhumesh, for that input. Yeah, Dr. Sarmania, sir.
Bhumesh, this HPV vaccine now is used as a treatment for what even? The perineal wart, vulval wart, it's been now tried as a treatment for what even? Dr. Sitaram, would you like to say something?
So the therapeutic efficacy of this is not established. In fact, patients who already have warts, if we give them vaccination, the protection is against the leftover strains, other strains. Suppose the particular wart is a strain 11, the person gets protection against 6 and 16 and 18. Therapeutic properties of this has not been proven, sir. It is mostly still a prophylactic. Hunt is on for therapeutic vaccines also, but the Gardasil is only a prophylactic vaccine, sir.
So thank you very much for all the panelists, Dr. Sridhar, Dr. Resham, Dr. Vibhu, and coming in, Dr. Bhumesh, for coming in the last time, Dr. Maniyar, sir. So thank you very much for joining us. And Dr. Rajiv, so thank you for the inputs of the biodetonase and the carboxylase. I will try to get it done. Thank you very much for all the panelists. Thank you for the organizing committee for giving us this opportunity to have this panel here. So thank you. Thanks a lot. Bhumesh, over to you.
Thank you,
sir.
sir. Thank you very much. As usual, the excellent moderation with a lot of take-home bells. So this is the area we need to sensitize in the even in the initial stage, we thought of some people even why this pediatric genital dermatosis, does it have any significance? Definitely, it needs high index of suspicion. It needs more and more the awareness. Even IAP, they are doing a lot of awareness activities in the adolescent age. It's even behalf of IADL, it's high time to sensitize more and more in the pediatric genital dermatosis. So thank you very much for all your excellent inputs. It's the time to sensitize our younger doctors, the postgraduates, because they are the main pillars for the institutions and the future generations. Now I invite the quiz master for this session, Dr. V. Shirisha, a good academician and the fellowship in the pediatric dermatology from CMC Vellore, and she is assistant professor from Osmania Medical College. Now over to Dr. Shirisha.
Thank you, sir. It's now time for the interesting part of the session, the PG's MCQ quiz. I'll repeat the rules once again. Each session will have 10 MCQ questions. You have to mark one correct answer and the first 3 toppers will be selected. Duration of time is 5 minutes and the quiz master decision is final. Please do not refresh or close the browser. All the best for all the PGs. Please go ahead with the quiz. Meanwhile, it's time for felicitation of our faculty. I request the chairpersons to felicitate the speakers, moderators, and panelists of the session. Dr. Srinivas Prasad, sir. Dr. Bhumesh Kumar, sir.
Excellent session, Bhumesh. Excellent presentations. Really very nice.
Dr. Sitaram, sir.
Dr. Sitaram, as usual, superb.
Dr. Arun Inamdar, sir.
Missed you.
Dr. Rajiv Sharma, sir. Dr. Sridhar Jandyala, sir. Dr. Vibhu, ma'am. And Dr. Resham, ma'am.
And to the quiz master.
Now I request the organizing team to felicitate our chairpersons, Dr. Dinesh Mathur, sir. Dr. Shamanta Barua, sir. And Dr. Madhubabu, sir. I thank the organizing team for the wonderful opportunity given to me. Thank you, sir.
Thank you, everyone.
Yeah, thank you, Dr. Shirisha.